Welcome, and thank you for joining us today. Today's webinar is on From Donor to Recipient, Navigating the Challenges of Donor-Derived Infections in Solid Organ Transplantation. This webinar is co-sponsored by the AST Transplant Pharmacy and Infectious Disease Communities of Practice. Before we begin the main presentation, we have a few housekeeping notes to help you engage with today's session. There is currently a viewership polling question displayed on your screen. Please take a moment to answer this question while we finish the remaining announcements. This webinar is being recorded, and the recording will be available next week on the AST YouTube channel and on the COP hubs. Please note that your lines have all been muted so that only the presenters and panelists can be heard for the archive recording. If you have a question for our panelists during the webinar, we encourage you to participate using the Q&A window or the Zoom chat in your Zoom webinar panel. Submit your questions for consideration, please. Questions submitted via the chat window, however, may be missed during the main presentation. Finally, at the conclusion of today's webinar, a short survey will appear on your screen. Please fill out the survey to help us keep our content current and engaging. I will now turn the session over to our moderator, Dr. Ford, to begin our presentation.
Hello, everyone, and thank everyone for joining. A quick introduction of myself. So my name is Edith Ford. I'm a pharmacist currently with Prisma Health in South Carolina, and I will be the moderator for the panel. In order of speaking time, we have our speakers today. Our first one is Dr. Silke Niederhaus. Dr. Niederhaus is a kidney and pancreas transplant surgeon and professor of surgery at University of Maryland School of Medicine. A two-time kidney recipient herself, Dr. Niederhaus completed medical school at the University of Alabama, Birmingham, from where she moved to Madison, Wisconsin for surgical residency and transplant fellowship. In her free time, which is sparse, she enjoys baseball and on any given day would rather be skiing. Next, we will have Dr. Miranda So. Dr. Miranda So is the manager of the Antimicrobial Stewardship Program at the University Health Network in Toronto, Ontario, Canada. Miranda received her Doctor of Pharmacy degree from the University of Toronto and Master of Public Health degree from the Harvard School of Public Health. Miranda is a clinician investigator with the Toronto General Hospital Research Institute, an assistant professor at the Leslie Dan Faculty of Pharmacy, University of Toronto, and a clinical lecturer at the Department of Infectious Disease Faculty of Medicine and University of Melbourne, Australia. Dr. So's clinical practice and research focus on antimicrobial stewardship in solid organ transplant recipients, hematology oncology, and stem cell transplant patients. She is the co-chair of the Antimicrobial Stewardship Work Group of the American Society of Transplantation. She is also a distance runner and a knitter, though she has not quite mastered doing both simultaneously. And then lastly, our last speaker will be Dr. Ann Woolley. Dr. Ann Ellis Woolley is the Weitzman Family Distinguished Scholar in Infectious Diseases and Clinical Director of Transplant Infectious Diseases at Brigham and Women's Hospital in Boston, Massachusetts, where she leads clinical care quality initiatives and research for solid organ and stem cell transplant recipients within a large multidisciplinary program. She earned her BSE in Mechanical and Aerospace Engineering from Princeton University and her MD and MPH from the Icahn School of Medicine at Mount Sinai. She completed residency and chief residency at Boston Medical Center and her infectious diseases fellowship through the Harvard Combined Program at BWH and Massachusetts General Hospital with a focus on the immunocompromised host. She is also a medical director for New England Donor Services, as well as an affiliated scientist at the Broad Institute of MIT and Harvard. She co-directs the clinical research unit at BWH for the Center for Integrated Solutions for Infectious Diseases and serves as principal investigator for several clinical trials focused on optimizing infectious outcomes and expanding the organ donor pool, including trials in hepatitis C and hepatitis B viremic donors, antimicrobial prophylaxis, vaccines, sepsis, and endocarditis. Dr. Woolley is deeply committed to mentorship, education, and training the next generation of transplant clinicians. And so with those out of the way, we'll go ahead and turn it over to our first speaker, Dr. Silke Niederhaus, and we'll get this started. Please feel free to drop any questions into the Q&A panel, and we will collect them and we will answer questions after the end of the presentation. All right, Dr. Niederhaus.
Yeah, thank you, Edith, and welcome everyone. I'm very thankful to have a lot of coworkers here, and you just saw everyone's disclosures, so we won't bother your time. We'll try to go a little speedy today because I hope to have some time for conversation at the end of this webinar. I think we learn a lot from talking to each other. So for today, I wanted to start everyone off by thinking about a case, right? So this is a case of a donor, a 36-year-old construction worker who was admitted as a trauma patient 2 weeks ago after a fall and crush injury when scaffolding at the construction site collapsed, right? This patient's now been declared brain dead, and the family has made a decision to go forward with donation. And as usual, you'll see that, the patient had their serologies done. And this one is a CMV positive, EBV positive, Hep B core antibody positive, Hep C antibody positive, and PCR negative donor. In terms of their other workup and for suitability of donation, the donor had other testing done, including an echo that shows an ejection fraction of 55%. The patient's ventilated. The vent settings here are given. The chest x-ray looked reasonably clear, even though on admission there was a good bit of atelectasis. The donor's currently on a little bit of vasopressors. The LFTs initially peaked at, the 200s, but have now normalized. The urine output overall during the hospitalization has been steadily over 30 milliliters per hour, but the creatinine started at 1.1, peaked at 3.6, and has now come back down to 1.8. So this is a donor that, likely is a multi-organ donor, and the recipients that received organs from this donor eventually include a heart lung that went to a 23-year-old male transplanted for congenital disease, a liver that went to a 47-year-old woman with NASH, a right kidney that went to a 54-year-old obese patient with type 1 diabetes, and a left kidney that was received by a 22-year-old patient with just severe hypertension as their described cause of kidney failure. In terms of donor-derived infections, right, when I take these organ offers as a surgeon, I think about like two things. One, what is known in this donor, right? So a lot of it we know from routine testing, as you saw a minute ago, the serologies. And then some other things are usually found out from a thorough review of the donor chart, right? So you would find that if there's an X-ray, there may be TB on it, or there are donor cultures that were drawn and resulted and entered into the donor chart. But I think much more tricky is to look at what is really unknown in the donor, right? What are the things that maybe the donor center didn't think to test for, or that were tests that could be helpful but were not indicated in the setting of a trauma? Sometimes the history of the donor or the hospital course can give us clues to certain infections that may be lurking but not apparent for us yet. So one of my favorite strategies is working with our ID team and then requesting more data, because I think the more we know, the better off we are. As a kidney and pancreas surgeon, I usually have time to ask for more. Other organs sometimes have a little more urgency. So we now look and see what happened theoretically to our imaginary donor and recipients after the transplants. And when we go through the recipients, the heart-lung patient develops a severe pneumonia 2 days post-op, and you can all use your imagination to figure out what that could be. Our liver patient was a woman who transplanted for NASH, was washed out on post-op day 1 for bleeding, not all that unusual, but then goes on to do well. The right kidney recipient, remember, was obese and had diabetes, had some delayed graft function, and eventually developed a urine leak on about post-op day 7 and had some urosepsis with an ESBL organism. And the left kidney went to the 22-year-old patient who did well initially, but then developed a severe rejection after about a month or so from non-adherence to medication. And after treatment for this rejection, develops a new mysterious lung nodule. And at this point in time, I think we need to really think about, these known infections and these unknown infections, right? So the known infections you see here highlighted in blue, right, were the serologies that we knew. I didn't really address the hepatitis C. Let's just assume that the, follow-up testing of the recipients was negative and no treatment was needed, or that they were treated appropriately, right? But if the story changes and we look at the next slide, the unknown infections are really the tricky ones, right? We have maybe this construction worker was someone who was born and raised in a different country or lives in a state like New Mexico, right? What could lurk there? What was the exposure on the construction site to, whatever grew in the ground, right? Maybe they had an open abdomen for a while and, had a positive blood culture that wasn't known at the time of organ recovery and ended up growing out 4 days later. Maybe same with a positive urine culture. Oftentimes at the time of donation and transplantation, we don't have all the information yet. So some stuff is hindsight. We go on. And other findings in the donor could have clued us into potential other problems, right? Maybe this echo that had the EF had a thickened mitral valve or other thickened valves. And maybe that was the only hint of some lurking endocarditis, right? Maybe an updated CT scan that wasn't loaded into DonorNet but was available at the donor hospital had a little wedge-shaped perfusion defect in the left kidney or in the right kidney. That then contributed to an infection, right? So in my mind, donor-derived infections are sometimes very obvious and sometimes manageable. Some of them are very subtle and even hidden. And so constant vigilance is in order when we go about evaluating our donors and even our recipients and figuring out if this organ that we're trying to pair is a suitable combination. At this point in time, I have the pleasure of handing off to Miranda So, who will go over a little bit more in depth of our donor-derived infections.
Thank you so much, and thank you for having me today. And that was such an interesting start of the presentation. I've learned so much already. So my section, I'll focus on antimicrobial management and stewardship in donor-derived infection. So maybe just to provide some context, why donor-derived infections matter. Well, if you look at the graph on the top left corner here, this shows between the year 2000 to 2024, the absolute number of transplantation has gone nothing but up, with the exception of a couple of years during COVID, but then it just went back up as if nothing had happened. In the year 2024, in the US, and this is based on UNOS data, US had surpassed 48,000 organ transplantation. And we know that a lot more patients are waiting for their organ transplants. And some might even not be able to get to that point, and patients have known to wait for a long time. And then the graph on the right, top right corner here, this shows kind of the density or the total per population number of solid organ transplant across the world. Certainly North America, Canada, as well as the US definitely has the highest rate, but also parts of Europe and Asia and South America as well as Australia. There are also many organ transplant happening. This is only in 2024. Now, infection is an important cause of morbidity and mortality after organ transplantation. And infections transmitted via transplantation because of the organ, i.e. donor-derived infection, is estimated to be quite rare, about less than 0.2% of all transplant procedures. But they actually confer very high morbidity and could even be fatal. Knowing that, every organ donor can save 8 lives and support 75 more, and this is data from, the organ donation website, this could potentially have a lot of implications for our transplant recipients. So if you have not come across this review paper, I strongly encourage the audience to go to Transplant Infectious Diseases, the Donor-Derived Infection Supplement from last year, a special issue last year. And this review paper by Dr. Vatke is actually very, very helpful. It's the first time I'm seeing this entire continuum of organ transplant process with potential infectious complications being presented in this way. It really helps me kind of think big picture, zoom out, look at the issues of donor-derived infections, pre-transplant infections, and connect that to the perioperative infections and some factors to consider, as well as the post-transplant period that the patient might be affected. So we'll focus on donor-derived infections today. And I wanted to talk about how, we work together for safe transplantation between transplant team, just like Dr. Niederhaus, Transplant Infectious Diseases, just like Dr. Woolley, and myself in antimicrobial stewardship. We work together to improve safety or transplantation, because donor-derived infections pose safety risks for the recipient. There are discussions about donor management, screening, and mitigate against both standard and non-standard risks. And emerging infections is also something we constantly be on the lookout for, as well as understanding the utility of donor cultures to guide our decisions. For the solid organ transplant recipients, they are disproportionately affected by antimicrobial resistance. And we know that AMR is associated with worse outcome after transplantation, but we also know that adverse events from antimicrobials may impact the graft function. And so antimicrobial stewardship is here to address antimicrobial resistance through optimizing antimicrobial use. We take a programmatic approach, and we focus on the quality of care and safety of both the individual patient as well as the patient population. So here are some suggested strategies and opportunities for collaboration. You see that I use this imagery of, a camera lens. I like this concept a lot because it reminds me that we're constantly zooming out to see the big picture at the system level, but also zooming in to look at specific things that are pertinent to the specific patient as well as the patient population. So together, we work together to develop institutional guidelines on surgical prophylaxis for organ transplantation based on donor cultures and the specific organ pertinent risks. We can also work together to develop protocols to facilitate antimicrobial decisions given specific donor culture results. And importantly, we communicate pertinent donor results with other organ teams. And this is important, especially when we know that one donor might be contributing to the organ transplantation of several patients. And then we also work closely with infection prevention and control, as well as other transplant centers, especially when we are noticing unusual things. We also try to expect the unexpected, as well as the expected, but also work together and develop mitigation strategies for the truly unexpected. For the antimicrobial stewardship team, we would also be evaluating and reporting on appropriateness of antimicrobial use in solid organ transplant recipients based on donor cultures, monitor and report adherence to the institutional guidelines for donor-derived infections, and we also follow closely local, national, and international epidemiological trends to update guidelines and protocols. So all of these things require us to zoom in and zoom out at the appropriate juncture, and I think it's important that we all work together. I wanted to kind of move a little bit upstream to talk about antimicrobial stewardship in donor management. We all want to prevent donor-derived infections. Hence, I have this imagery of a big red umbrella protecting the patient from this pouring rain. So to prevent donor-derived infections, antimicrobial practices in donors who are being prepared for organ recovery could vary, including according to the local organ procurement organization policies, as well as specific societal recommendations. So there are some variations if you read one paper to another. But to minimize the risk of infection transmission to the recipient, a lot of the guidance ask the centers to actively pursue all possible infections in the donor, typically administer broad spectrum antibiotics to the donor for at least 48 hours before organ recovery, treat colonization status empirically in the absence of clinical infection. But some guidance have also suggested maybe it is okay just to treat only the documented infections, the known infections in the donor. Like I said, there are some variations, but some would also suggest that the centers monitor the donor's physiological response after the administration of the antimicrobials. Now, besides the donor, there are also specific adjunctive risks for the organs. So, sorry, just excuse me 1 second. My apologies, that was unexpected. So I wanted to talk about, sorry. So the adjunctive risks factors for the organs themselves also deserve our attention. Infection from advanced perfusion techniques, this has been a major contribution to improving organ donation. For example, ex vivo machine perfusion, perfusion strategies, the duration of the perfusion, the perfusate components, and the antibiotic regimen that's given on the circuit, as well as the infection prevention practices for the perfusion techniques could also play a role in terms of these risks to the recipients. On the topic of the role of preservation fluid, microbiology guided antibiotic for treating donor-derived infection, I think this remains a bit of a debate, and there's definitely a knowledge gap. In terms of risk assessment, donor risk assessment and serological testing and cultures to support antimicrobial decision is pretty standard practice. If it is known at baseline, donor history, including epidemiological or environmental exposure, history of the infection or colonization at the donor's terminal hospitalization, as well as the mechanism of death and pre-hospital course, if known, that's certainly factored into the decision. Specifically to MDROs, multi-drug resistant organisms, prolonged hospitalization, prior colonization, exposure to antibiotics and indwelling devices, as well as the need for dialysis, have also been found to be associated factors. Oftentimes, the surgical prophylaxis would be modified in accordance to these, specific pieces of information. And if indicated, the post-procedural antimicrobial regimen would also be targeted accordingly for those MDROs. As Silky mentioned, the screening for the HIV, HBV, HCV, CMV, EBV, syphilis, Chagas, TB, toxo, West Nile, these are all standard recommendations. I want to highlight a kind of a system level intervention using donor cultures to support antimicrobial stewardship in recipients. So this is a study from Italy, and it's a comprehensive donor surveillance program to detect carbapenem-resistant gram-negative bacilli. And they have collected specimens from the donors for blood, respiratory specimens, urine samples, as well as preservation fluid. And the risks would be interpreted in the context of the organ particularly. So, if it is blood culture, obviously that's different. But if it is urine culture versus a set of lungs going to the recipient, that's all interpreted in this context. If the results are known, the organ recovery process would include the targeted antibiotics for those MDROs. If the results are unexpected, then they have implemented a timely communication to the recipient centers. As a result, they were able to shorten this communication period from 10 to 15 days to 1 to 5 days. So that's much more helpful to support the transplant centers. However, it is a resource intensive program, and I do wonder about the sustainability here. I wanted to kind of turn towards a little bit on the emerging pathogens. So in this table, it talks about kind of more recent years important emerging pathogens, such as COVID, Mpox, HTLV1 and 2 molecules. So that would be the Mycoplasma hominis and Ureaplasma species, Strongyloides, and Cryptococcus and mold. So I won't read out all the columns, but I just wanted to highlight this provides kind of a good way to think about the risk stratifications. For myself, as a stewardship pharmacist, I wouldn't be the person ordering these tests or interpreting the tests, but it is my job to understand the indication for the antimicrobials that the recipient is receiving. So if I know about this background information, I can connect the dots and understand and, assess the recipient's antimicrobial regimens when I'm doing antimicrobial stewardship rounds. So this is certainly helpful information to have. Focusing on the mycoplasma and ureaplasma infections in lung recipients, just wanted to highlight this because this is an important aspect and specific to lung recipients. So mycoplasma hominis and ureaplasma species are urogenital molecules, and they could cause serious donor-derived infections, specifically in lung recipients, with the acquisition rate estimated to be about 2 to 5%. The infections tend to occur early post-transplant, and the syndromes could be pneumonia, but it could also be extrapulmonary infections as well as surgical site infections. But most significantly, the morbidity is hyperammonemia syndrome, encephalopathy, and with unexplained high serum ammonia levels. And this confers very high mortality, up to 80%. Routine screening has reported a prevalence of about 10%. And usually in donors, specific factors include young age, female donors, history of high-risk behaviors have been identified to be associated. In a single center study by Tam and colleagues, they found that donor screening via cultures may have better positive predictive value than PCR, but neither test was able to predict all the infections in their study. So I think this is still something that is to be standardized. In terms of mitigation, screening plus treatment with a combination of quinolone and a tetracycline or macrolide have been recommended. This combination is because of notable rising resistance. And lastly, I wanted to talk about Strongyloides stercoralis in organ transplant recipients. Now, strongyloides is considered a neglected tropical disease. In the past, it was, discussed in the context of, reactivation in previously exposed recipients. But more recently, it's recognized that donor-derived infection might pose a much greater risk. And recipients are at risk of hyperinfectious syndrome or disseminated disease, and with fatal outcomes as high as 85%. Bacteremia and/or meningitis have also been observed in 50% of the cases. Now, donor-derived infection here is rare, but it's an emerging challenge because of the with poor outcome. It's been linked to the fact that presentation might be variable, and the diagnosis might be under-recognized, resulting in a delay in treatment. And so donor screening currently recommended to be based on epidemiological risk factors, including country of origin and travel history. And if suspected or proven infection in this situation, then the prophylaxis would be given to the recipients with ivermectin 200 micrograms per kilogram daily for 2 days, then repeat in 2 weeks' time with ongoing monitoring. And with that, I'm going to hand it over to Anne for the next part.
Thank you so much, Miranda. So I think that's always interesting when we're asked to speak about the challenges of donor-derived infections. And what I'd like to end for the third talk during this webinar is thinking about this a little bit differently, and thinking about this in terms of beyond the red flags. How do we use infection-informed strategies to safely increase organ utilization? So essentially, how do we turn the challenges of donor-derived infections into opportunities to expand the organ donor pool? So we know across transplant in every field of transplant and medicine, there's a spectrum of risk attitudes that's applied. So this was a wonderful article that was written and published in Transplantation International in 2022 that talked about these different risk attitudes. When you think about risk avoidance, risk being a risk averse, risk neutral, risk tolerant, or risk seeking, I advocate that we think about how we can become more risk tolerant by focusing on the positive risk, but also negative risk must be considered. And really overall thinking that risk is good, but unacceptable in certain circumstances, and therefore leading towards the fact of saying in transplant, accepting most organ offers as any organ is better than no organ in the majority of cases, not all, with more refined analysis and assessment depending on the particular recipients. Overall, leading to benefits being greater than the risk, and really having an ideal optimal attitude for this. So really thinking about this in terms of when to say yes. How do we select organ donors with infectious complications? We know that there are many complex patients with known or suspected infectious complications that can still be suitable organ donors and lead to good outcomes. They often have medical and surgical complexities, and we know that our organ pool is only increasing in terms of the complexities of our patients. And often they'll have varying forms of infectious complications, either a known history of having infections or having a chronic infection, or not having a prior history of infection, but having a current active infection at the time of organ evaluation. So Miranda nicely took us through the different buckets of donor-derived transmissions. And really when we think about the case that Silke presented and what we'll talk about now, is it really focusing on bacterial infections, the risk or concern for fungal or parasitic infections, and viral infections. So I'd like to take us through a case that we've had in our region, and these are slides courtesy of Victor Kovac, who was my fellow at the time, in terms of a young woman who presented with fever, stupor, and double vision. And you can see that she had cavernous sinus thrombosis, jugular thrombophlebitis, cerebritis, and ventriculitis. She was intubated. She underwent an LP and had a very elevated opening pressure of 60 and 1,000 total nucleated cells on her CSF. She was empirically treated with vancomycin and meropenem, put on a heparin drip. Hyperosmolar therapy was determined not to be an EVD candidate, and ultimately had refractory cerebral edema. Wouldn't be an ID talk if we didn't show a gram stain here that you see at the right. This was what grew in 2 out of 4 bottles at 72 hours after admission, and then ultimately was speciated as Fusobacterium. The manifestations of this syndrome and what this patient, who ultimately became a donor, had included pharyngitis, a deep neck space infection, septic jugular thrombophlebitis, or as we know with the eponym, Lemire syndrome. So in this young woman who came in with fever, was found to have Fusobacterium bacteremia, jugular thrombophlebitis, cavernous sinus thrombosis, and cerebritis, and went on to have progressive cerebral edema and ultimately was declared brain dead. Would this be a suitable organ donor? And if so, which organs could be safely offered from this donor? You see the echo here that didn't show vegetations, no septic pulmonary emboli on the CT, and no abscesses, infarcts, or other septic emboli in the abdominal organs. Fortunately, this organ donor went on to be able to have multiple organs, both thoracic and abdominal, transplanted, and those recipients were all doing excellent, and we had more than 18 months of follow-up for those recipients. So really, this is to really show us that we need to think about the framework that we use in how we accept infected donors. We have to understand the risks of possible transmission that Miranda nicely took us through and Silke took us through, and the different ways that we can mitigate the risk in terms of now that we have improved diagnostics for both donor as well as recipient testing, the interventions that we have to reduce the incidence or severity of disease. And then we know, like everything in transplant, it's a case-by-case risk-benefit analysis, and we need to think about it in terms of organ-specific. But really, when we think about the challenges of donor-derived infections, we're thinking about the unexpected donor infections. And those are often the cases that get the press, both scientific press and lay press. But what we want to think about is how do we turn this upside down and thinking about those that were expected or known donor infections, and how do we use that as really an opportunity to expand the donor pool and increase organ utilization. So now I'd like you to look at this checkerboard, if you will, of 12 different infections or syndromes, and think whether or not, if you were to encounter a donor that had these infections or syndromes, if you feel that organs from these donors could be safely transplanted. So these are donors that are bacteremic. Let's say they're bacteremic with MRSA for days, may or may not have endocarditis as well, could have bacterial meningitis, could have meningoencephalitis, could have a perforated bowel and perhaps an open abdomen, could have history or suspicion of aspergillus or cryptococcus, could have a respiratory virus such as influenza or HSV encephalitis, could have active or prior exposure to hepatitis C, hepatitis B, or HIV, with hepatitis C and hepatitis B being the case that Silke took us through, having triple E, or encephalitis of an unknown cause. So I would put forward that all but the bottom right two, triple E and encephalitis of unknown cause, should be considered and very well can have organs from these donors with these infections and infectious syndromes be transplanted to recipients and lead to good outcomes. I'm sure a number of these make you pause, particularly cryptococcus. We're all well aware of the multiple reports of donor-derived cryptococcus disease that often leads to poor outcomes. But we know the difference in those cases is that the donor was not known to have crypto, and therefore the donor was not appropriately treated, and the recipients therefore could not be put on antifungal treatment in an effort to prevent transmission or at least minimize the severity of infection in the recipient. And yet still, even when our recipients unknowingly develop donor-derived crypto, let's say a few days to often weeks post-transplant, often a large proportion of those patients still do well and have good outcomes. And so what can we do about now when we think about donors that are known to have crypto? And can we think about this? And so just that can be applied to many of these other boxes here on this slide. Well, what about respiratory viruses? So we know that flu, RSV, adeno, parainfluenza, SARS-CoV-2 have all been transmitted from donors to lung recipients, but only in certain cases have these led to increased morbidity and mortality. So where does that leave us when we think about as a transplant community? How should we approach these lung donors? Should we test all lung donors with an extended respiratory viral panel and not accept organs if the donors test positive for certain versus any respiratory virus? Well, we know the answer is somewhere in the middle, and we don't know what that answer is. We know that we learned a lot from SARS-CoV-2 in terms of saying that for lung donors, it was very important to get a lower respiratory tract sample to know. It didn't necessarily mean, and no longer in 2025 is it translating to mean that we can't accept organs, lungs even, from donors that do have a positive SARS-CoV-2. It's a fact that we have to manage the donor and the recipient differently. But we have to think about this beyond just the infectious complications, because we know with many of these infections, particularly our respiratory viruses for our lung recipients, these carry non-infectious sequelae. In the peri-transplant period of time, it increases the recipient's risk for having primary graft dysfunction or respiratory infection. There are short-term complications such as acute cellular rejection or antibody-mediated rejection. And then, of course, we know that many of these viruses go on to predispose our transplant recipients for developing chronic lung allograft dysfunction. However, what we really need to know, and what I think the challenge to us as clinicians and transplant infectious disease physicians with our transplant colleagues, is to understand in which patient is this going to be the case, and how do we manage our recipients in terms of antivirals at the time of transplant, but also immunosuppression post-transplant in a way to try to minimize some of these non-infectious sequelae. So to that means I'd like to shift focus in thinking about how can we manage our donors and how can we specifically manage the grafts. So we know that ex vivo machine perfusion have really revolutionized what we're able to do in transplant now in the past 5 to 10 years. It increases the time that we have to accurately assess donor organs and diagnose issues, ultimately improving organ utilization. It gives us the option to treat, have the organs recover, repair, and therefore using a targeted approach. And it also gives us the opportunity to then reassess the organ in terms of the graft quality, therefore allows us surgeons to confirm the results of treatment. Well, how does this apply to us when we think about minimizing donor-derived infections or being able to utilize organs that come from donors with known infections? Well, we need to turn to the real principle and fundamentals of transplant infectious diseases that was taught to us by one of the greats and the giants in the field, Bob Rubin, showing us that whether or not a patient is going to develop an infection and how severe that infection is really determines or based on 3 main factors. the pathogen inoculum, as determined by the exposure, environmental exposure or whatnot, the virulence of the pathogen, over the recipient's net state of immunosuppression. Well, when we think about ex vivo, and I'll focus on lungs in this case, ex vivo lung perfusion, but this could be used in other organ types for ex vivo machine perfusion. When we think about the different antimicrobial strategies that could be used, it's not really going to impact the virulence of the pathogen, nor the host or how immunosuppressed they are. But it can impact, and we can have some leverage in decreasing the inoculum effect. So here, if we have a schematic of the ex vivo lung perfusion system, and think about where could we intervene in terms of infection intervention targets within this system. So you think that you could intervene in the reservoir with using the perfusion solution, and could we give antibiotics, antivirals, different things there we could put in the reservoir to impact then what the organ is receiving before we then transplant those organs. What about the leukocyte filter? Can that be impacted so that we decrease the amount of particles or so that could then pass through and therefore screening out some of the pathogens? Or can we add a UVC irradiator to help then minimize the transmission and decrease the inoculum effect? Well, let's look to this. Unfortunately, we have our colleagues in Toronto that have done a lot of work in this area that we can learn from. And so one of the things we want to think about in that is, could we reduce the pathogen load? And if so, would that be helpful in our donors that have pneumonia? Or this could also be applied for donors that are bacteremic. So these studies looked at EVLP enabling localized high-dose antimicrobial administration without systemic toxicity. So we know that EVLP can allow for supratherapeutic drug levels without associated toxicity to other donor or recipient organs. The vancomycin perfusate concentrations can be 30 to 40 times higher than the threshold for renal toxicity. And meropenem perfusate concentration was shown to be maintained around 1,200 mg per liters over a 12-hour run, which is much, much higher than the MICs to meropenem. The protocols combining Cipro, Vanc, and meropenem showed significant reduction in the bacterial counts in the BAL. However, is this actually clinically significant? If you're just decreasing this, but you still have bacteria that's there in the graft that we know that will only increase then in the recipient due to the immunosuppression, are we really helping? And also, do we really think those high levels of antibiotics come without any detriment to our recipients or to the graft itself? Probably not. Because we know that with the reduction of the pathogen load, it does lead to endotoxins. Because gram-negative bacteria release endotoxins during cell replication and death, and the lipopolysaccharide molecules are found in the outer membrane of gram-negative bacteria. And LPS is highly pro-inflammatory and triggers a massive immune response through the toll-like receptor 4 activation on immune cells. And this immune cell activation can cause cytokine storm, tissue injury, worsening lung inflammation during EVLP, and overall impaired lung function, even if the bacteria themselves are killed. And though EVLP does allow for removal of endotoxins, not fully. So it's not completely free when we think about trying to reduce the bacterial burden. And also we have to keep in mind that while reducing bacterial pathogens, antibiotics disrupt the microbiome homeostasis. It causes a diversity loss. Broad-spectrum antibiotics deplete the commensal bacteria. It causes pro-inflammatory shifts. And also there's an association with pulmonary graft dysfunction that's been seen in our lung transplant recipients. And so there's many benefits: decreasing bacterial burden, salvaging marginal infected lungs, and reducing the immediate infection risk. We also have to think about the associated risks associated with this to the non-infectious things, such as sustained inflammation from residual endotoxins, etc. Well, that's bacteria, so that's not the end of the story there, but at least it's something that we can think about. Can we learn more and do more in that area? But what about viral infections? Are there things that we could do to use EVLP to treat that? So we know that the combination of EVLP and light therapy enhances viral inactivation through targeted oxidative damage and mechanical clearance. We know we have different ways we could do this through photodynamic therapy or UVC irradiation. And there's many advantages for this. They're safe for graft function and it synergizes with EVLP's mechanical clearance. Well, let's show an example of this. Again, our Toronto colleagues looked at this in terms of hepatitis C. They published on their single center study of looking at 22 hep C NAT positive donor lungs that they transplanted into hep C negative recipients. Before implementation, all hep C donor lungs were treated with EVLP with or without UVC perfusate irradiation to reduce the concentration of hep C RNA and infectivity. Then the patients received 12 weeks, a standard course, of sofosbuvir velpatasvir, starting around 2 weeks post-transplant. The primary endpoint was a composite of survival and hep C-free status at 6 months. Now, before I get to the results of this, I want to contrast it with our center study, where we also were looking at transplanting thoracic organs from hep C NAT positive donors into hep C uninfected recipients. We did not use EVLP. Instead, we used a prophylaxis shortened antiviral treatment that we started on day 0 right in the OR at the time of implantation of the organ. I want to call your attention to the panel on the right, because I think this was the thing that we learned most from this study, that the recipient baseline hep C viral load that was drawn right after the organ was implanted was directly proportional to the donor hep C viral load, though a few logs lower, showing us that this is not something that's one size fit all, that it's very much dependent on the donor quantitative viral load. So that would argue to say, well, this is great. Then EVLP would be wonderful, because if we could reduce the viral burden that we're transmitting to our recipients, then this would allow us to be able to treat more of our recipients for shorter courses and also not worry about as much. And perhaps we could prevent transmission to our recipients. However, that was not the case. So the panel on the left is the EVLP plus UVC arm, and the panel on the right is our cohort of just using antivirals beginning on day 0. You can see both cohorts had a similar proportion of patients, 91% in the Toronto group, 95% in our patients, who had detectable hep C viremia immediately post-transplant. The difference was that in the Toronto group, they had a higher viral load once they developed it, which is or peaked to it around day 14. But they started initially with a very low viral load, and it took them around 7 to 14 days to get that high viral load. In our cohort, the initial viral load was much higher, but that the decay to the viral load after starting antiviral treatments, for some reason, was slower in our cohort, whereas post-EVLP, it was a much swifter viral decay. Unclear exactly why. But the end result was that all patients still needed to be treated. And we did see 2 patients that had had hep C relapse within 3 months in the Toronto group. And in our cohort, there was no relapse. I don't think that's the difference here at all. We know that the more patients we do, we're going to be to have a chance of perhaps seeing a relapse or 2. I think the bigger critical thing is that this was an amazing demonstration to us to show that you can use EVLP to decrease the initial viral burden that the recipients see, and then also to delay when perhaps treatment would be needed. However, we know that EVLP is not necessary for hepatitis C. It's a curable RNA virus with highly effective and well-tolerated antiviral treatment. But the concept that they showed, I think, was very critical and now can be applied to other viruses. Can we reduce donor transmission of the more difficult to treat persistent viral pathogens, such as what we're looking at now with them in terms of hepatitis B or EBV or CMV for our seronegative recipients? So what are the next steps for utilization of hep C donor organs? I mean, when you think about this, 10 years ago, this was such a controversy. Should we do this? We know that we had a precedent at that time for donor-derived infections with CMV, which is not curable and we lead to many more non-infectious complications. So fortunately now, transplanting hepatitis C positive donors is standard of care. Though we did see, and I think it's important for us to still look about some of the non-infectious causes as far as having an increased risk of acute cellular rejection, perhaps. But fortunately, longer-term data have not shown a higher incidence of chronic lung allograft dysfunction or CAV or rejection in our abdominal organs. But can we apply this strategy to accept hepatitis B, surface antigen, and or not positive organs? The question is not can we. It's really now, in 2025, how do we? And not about the why or who or why nots to do it, but how, which combination treatment, when to start it, how long to continue the treatment. So we have multiple case series that are coming out now that are looking at this. I want to highlight this one from March of 2021. This was in our kidney transplant recipients. When it's we have to be careful with all our hepatitis B data that is out there, because it's often mixing apples to oranges in terms of not all the donors are both surface antigen positive and NAP positive. Some are a mix of those. And then it's also very determined as far as, or depends on the recipients in terms of whether or not they were surface antibody positive. In this cohort, 24% of the patients were surface antibody negative, whereas 3/4 were surface antibody positive. A different proportion, only half got HBIG, and then about 3/4 of the patients received antiviral treatment. Though it showed that there was no difference in graft or liver function, rejection, or infection, there was a higher mortality in the Hep B surface antigen donor positive recipient negative group. Unclear why, and we need to see more. And we have more data that's come out in 2025 from our Duke colleagues, as well as our colleagues in Edmonton, that it continue to show that this is feasible and can be done in thoracic organs as well. But there's a number of questions that are still out there in terms of how do we manage the recipients in these cases? Hepatitis surface antibody status in the recipient. How should that impact what we do or don't do in terms of treatment? Should we only be accepting these organs for Hep B surface antibody positive recipients? Probably not. We can manage these in Hep B surface antibody negative recipients, though we should be trying to vaccinate all of our recipients, of course, but we know that not all mount a good, robust response. Should we be committing our patients to lifelong antiviral treatment, since unlike hepatitis C, this is not a curable virus? If not, how long should we be treating, and should this differ in terms of whether or not our recipients are Hep B seropositive or not? And then what is the role for HBIG? Should we borrow from the hepatic literature in terms of giving multiple doses of HBIG? And does that remove the need for oral antiviral treatment? So our center, as well as other centers, are doing a current clinical trial, which hopefully will answer some of these questions. But just an ending in terms of when to attempt to eradicate infection via EVLP. I think we need to think about this as a possible mechanism, but not for all infections. We want to think about this in donors that we could use this to benefit in blocking transmission of the viruses that are very hard and difficult to treat without having significant side effects with that, compared to right now using it for bacterial pneumonias or bacteremias where we have good effective treatment for our recipients, and therefore maybe the side effects outweigh the benefits of this. But finally, I just want to end with, I think, a very provocative and important quote for one of our excellent transplant surgeons in the field, Dr. Robert Montgomery, that he published in his personal experience in New England Journal of Medicine in 2019. He says, "For the doctor, it's always easier to avoid risk, but certain kinds of risks are more difficult to accept than others. For instance, we perceive greater risk in acts of commission than in acts of omission. If a patient dies during or after transplant, it's the doctor's responsibility. But if the patient dies from organ failure while awaiting a transplant, we can blame the indifference of the universe." Thank you.
Alrighty. Thank you so much to our presenters. I'm going to dive right into the questions since we are coming up on time, and there are some fantastic questions in the chat so far. So first question, and these are not addressed to anyone specifically, so whoever wants to jump in. So the first question is that many centers are hesitant to transplant candidates with Candida auris infection or colonization because of concerns about increased mortality and morbidity associated with Candida auris. Donors are not currently being screened for Candida auris. Is this something that should be considered? We might think twice about kidney from donor with Candida auris colonization who has yeast in urine culture and had a Foley catheter, or similarly may think twice about using lung in a Candida auris colonized donor with sputum bronch cultures with yeast who is maintained on mechanical vent support. So is this something that we should be screening in donors, or is there maybe specific types of donors that we should be screening this for?
I'm happy to weigh in from the ID perspective. I would say I think we have to be careful with screening, because we need to make sure we have a targeted reason for screening, and then knowing that if we expand screening, It obviously helps in terms of mitigate potential risks in our recipients. However, it also can decrease organ utilization and make us very concerned about accepting these organs. We don't screen all our patients for CRE or whatnot. And so I think we have to think about this in the terms of the context of epidemiologic as far as the donor hospitals. I think that's the part that we really need to have more and more. And just like Miranda was talking about the antimicrobial stewardship perspective of it, we don't put everyone who is CRE colonized on an antibiotic just in case they grow a CRE. Because if not, we're just going to increase the resistance. And so I do think in patients that have particularly potential renal donors that have a positive yeast on a urine culture, then yes, those are things we should try to be able to, as our diagnostics are improving, we should be able to get that in real time to be able to know then, is it Candida auris or is it from an area or a hospital that is having a higher risk of that or whatnot, rather than thinking that this is universal screening in donors would be my perspective.
I'm actually going to add on to that question a little bit. Would you consider like more universal screening in endemic areas? Because I know I did my training in Arizona and like California and New Mexico were endemic. Would you consider trying to do more universal screening in those areas, or just kind of broadly?
Screening for Candida auris?
Yes.
So I don't think we're there yet. I don't think that when we think about the proportion of, the cases that are needed to have to really say that the benefit of doing so outweighs the potential risks and the additional, with everything that we try to do and need to do in terms of testing of our donors, when we think about all the burden that lies on our organ procurement organizations and the stewardship that they also have to do with this, right? From diagnostic stewardships as well. I don't think we're there yet to say we should be screening. I think it should be a donor hospital thing. I think it should be driven by the antimicrobial and diagnostic stewardship teams in the hospital to determine that. Then, of course, if it gets to a certain level, and I think those are things that need to be reassessed often.
Perfect. All right. So the next question, rather than each accepting donor surgeon trying to get an individual infectious disease physician opinion, why don't the OPOs potentially consult with a single ID physician where there are infectious issues or the cause of donor death is not clear?
I'm happy to give one perspective. I think it's really fortunate that OPOs are moving towards this. That I'm aware of that at least 4 OPOs now have a medical director. As I mentioned, I'm a medical director for our OPO for New England Donor Services, and I'm aware of 3 others as well, and then additional 2 others that are consultants for their OPOs. And so I think very much so it's important to think about that, because also it allows us then to have the transplants receiving centers, regardless of where it is throughout the country or in Canada or whatnot, be able to pick up the phone and call us too with it because it obviously depends also on the organ that's being accepted. And so I completely agree with that. And I think more and more are doing that. And it's important to have more ID on the taking donor call as well, so that we can become more versed in what's out there and what we can get and how can we actually manage the donor. Can we ask for additional things to be given to the donor prior to procurement if there is time?
Perfect. All right. Next question. Can someone comment on the issue of blood culture contamination in donors? We sometimes see this reported as 1 out of 2 bottles positive in the donor for gram-positive cocci, and the recipients are started on gram-positive coverage, such as vancomycin for like full 17 to 14-day course of prophy. So just wanting to see like what y'all's thoughts are on the contamination in donors and whether recipients need to be treated with a full course for potential contamination.
I will take a stab at answering this, but Anne and Silky, please chime in. I think this is where I would take Silky's line, ask for more information. I'd probably try to understand, was it true? I don't want to be, because there's a time lag, I don't necessarily know if it is truly a contaminant. Sometimes it's important for me to actually go back to the donor culture report and get more information there. And I would also obviously talk to the primary team to understand, oh, I saw that you started vancomycin. Is it because of this one positive result that I saw in the donor culture, or was there something else that maybe I didn't know? So for myself, my approach is I'm seeking clarification so that I can understand what the intention and the indication is. I think the other discussion with the primary team is, well, what do you think is the risk of this positive blood culture for this recipient? Do you foresee something bigger than just, one positive culture? Because that's when we can negotiate perhaps the duration of the vancomycin or whatever it is that the antibiotic is started, and have a discussion on the planned duration. Sometimes it's not over one discussion. It might be taking another couple of days when the primary team feels, oh, actually the patient's doing fine, we don't need to worry about this too much, then maybe we could do shorter. So it's not a black and white discussion, but it does demand or require at least, good dialogue.
I agree with that, Miranda. I think it depends on, how the patient is doing, right? If they're having signs or symptoms that are worrisome, right? For example, in kidney world, right, which is where I spend most of my time, if the kidney's not working right, if a CT scan or something shows infarcts now all of a sudden, I'm going to err more on the side of overtreating. On the other hand, if the kidney's working well and they're making urine, I'm going to say, well, we already gave antibiotic prophylaxis at the time of surgery, and that should be sufficient, right? If I truly think this is a contaminant. So I think it becomes a very case-specific scenario, right? What else was there on the donor chart that might make me worry or make me less worried? And then I adjust, what to do.
Absolutely. And I would also say there's always more information that we have in DonorNet. So just like Silke and Miranda are saying that we can ask for more, we know these don't become donors the day they come to the donor hospital. And so though OPOs do all they can to really put as much information into DonorNet, there's always more that usually is there. And so if this is one blood culture that's positive, I think it's less important to know to make that distinction as a contaminant or not, but think about it as we do clinically. There can be transient bacteremia. Let's say it's E. coli or whatnot. It's one positive blood culture. The donor often has gotten antibiotics around that time, at least 48 hours, often prior to organ procurement. That may have been sufficient. And so not everything that's in the donor we know gets transmitted. We know the fact that when we do have donor-derived infections, it's often, it's not always 100% of the organ recipients that get that either. So I think we have to take into account the recipient part, but also the way we would actually clinically think about this in the donor too.
Perfect. I know we're running a little over on time. There's still a few more questions. Just want to be cognizant of everyone's time. Do we have time for the panelists to answer a couple more questions, or do y'all need to hop off?
Dr. Ford, if you'd like to ask one or two more questions, we should have time for it.
Okay, perfect. Okay. Next question. What is the best practice for management of positive urine cultures in donors, or does this depend on the organ? For example, if you have a donor with ESBL in the urine culture, but no bacteremia, doesn't grow anywhere else, but the recipient is getting the liver, should the liver be treated with a carbapenem, or would you only potentially treat the kidney recipient?
I would treat the kidney, maybe not even the kidney recipient, right? I think, again, it depends on the history, right? If that donor really just had it in the urine and there's no hydro on the imaging and the donor was appropriately treated, there may not be anything necessary. As a surgeon, I might want to not put a stent in if there's no solid reason to have a stent to minimize anything there, right? That may be one of those scenarios, or try to shorten the duration of a Foley catheter, maybe even send a repeat urine after 1 or 2 days in the recipient to see if there's anything to treat. But I don't think that every urine culture that's positive in the donor necessarily needs to be treated in the recipient. Not even in kidney.
Absolutely agree. And I think it also depends on, we often don't get the dates of these urine cultures. So sometimes these urine cultures, maybe 4 days or so before organ procurement, they've gotten treated, they've had necessary treatment or whatnot with that. And so I think you have to take that. I do usually recommend that the peri-operative antibiotics be targeting what the flora was from the donor, especially in a kidney recipient. For the question in terms of the liver recipient, no. And keeping in mind that all donors do get blood cultures drawn at the time in the OR before the organs are procured, or at the time organs are procured. So we have that also as an additional data point. I think it's very helpful for us that in our to use urine cultures results in the non-kidney recipients to be able to understand the flora and as far as how colonized are they, the different pathogens, if they develop something in the peri-transplant time period that's concerning infectious-wise, to help direct empiric antibiotics, but not to just blanket the recipients and antibiotics. Hopefully Miranda's happy with that answer. We're trying to be very, very good stewards.
Okay. This is a good one. How do you alter public perception about organ transplant when the affected recipient has a serious adverse outcome that makes national news, such as, I don't know if y'all have seen, it's come across my news feed, the recent death from rabies. So how can we alter public perception about organ transplant despite these incidents?
I think two things, right? I think one, we have to highlight the positives, right? Our brains always, and this is what the news does too, right? We look for the negatives and the sensationalist things that happen, and we forget all the good that happens all day, every day, right? All day, every day, right? All the airplane crashes are on the news, but all the airplanes that safely take off and land and get people where they need to go, we never talk about them, right? And I think this is a very similar situation. And I think the key to it is education and focusing on the positive, and then also understanding that, we can't at this point in time afford to screen for every last little possibility, right? And I think it's incumbent on us as people who take organ offers to really review the donor history as critically as we can. And when we have questions, ask for more data, right? And if every now and then also understanding that things happen, right? I think it's part of a normal consent discussion with the recipient that sometimes diseases do get transmitted from the donor to the recipient, and sometimes that can lead to death or other severe events. And so I think just educating the public that nothing we do in life is risk-free, and that there are sometimes things that even if we try our best, we just can't foresee, right? That's how life is.
If I can add to that, I think the other part this gives us the opportunity to say is, again, this was unknown. That there are so many more known infections that we encounter in our donors that we can manage, that these ones being sensationalized, I think they should very much so be brought to the news so that people are aware of these unknowns, like Silky is saying, because really what that drives at is how can we be better in diagnostics, not screening everyone, but how can we get more clinical information from donors that we know are challenging for, obviously, it goes down saying in terms of what leads to their death or whatnot, when we can't often get all the information. But how can we try to get more information? And how can we really think about this in terms of our OPOs that are doing everything they're doing on the screening and testing and the information they get? How can we as transplant recipients, centers, really be looking at that primary data? And then if we need to ask additional questions, that we do. And it's really those unknown causes when we don't know why a donor has died that should give us pause. But we should really, I think about it in terms of public perception to say that we still have a hole, right? And that's why I showed in that checkerboard, we still have those areas, either known ones that we can't treat or the unknown causes, which are the ones that are that should give all of us pause to accept. Is it that they need more testing, or is it a case that it's too unknown and too high risk for one of these that it should be paused? Whereas those that have known infections, those aren't the ones that are coming up in the news. Those are the ones that we can treat and manage.
And then it depends on the recipient, right? I think the unknown and the risk you're willing to take may very well vary from this recipient will die if they don't get an organ or another offer in the next little while, as opposed to our high PRA kidney recipient, right? They don't get any offers, haven't had anything in 10 years. Maybe we need to be willing to take more of a risk for them, than others that get called every other day for an organ, right? And they have the luxury of, getting transplanted tomorrow with something else. So there's a lot of things that influence this kind of decision making, but it's also our job to be good detectives. When we're reviewing organ offers, we need to be detectives.
Okay, perfect. The next one is actually a question for Dr. Woolley. There are a few reports of donor-derived infections due to free-living amoeba, understanding these infections to be very difficult to treat with very high mortality, unlike crypto or aspergillosis, for which we have appropriate therapies. How would you approach these donors, recipients, when it comes to accepting organs?
Very carefully. I think what it means is that you would have to have time to be able to, first, you'd have to have the diagnosis so that we would know, is it one that we can treat? And that's why I used the example that I did of the amoeba, knowing that we do have treatment for that. Is it can we actually have not just a one-time dose, but a few days or so to understand, can we actually be treating and decreasing the potential inoculum risk in the donor to minimize the transmission risks? And is it a recipient that we can feel comfortable being able to use these treatments such as ambisome or whatnot that we know come with toxicities or so. So I think these are a very case by case basis or so with that. I think the reason it's important to think about that is that we have to think about this in terms of our donors, right? So we have not a small proportion of donors that the mechanism of death is drowning. And so depending on if it's freshwater, saltwater, or whatnot, what are the risks? There's all different parasitic and fungal things that we need to think about in terms of that. And I'm not suggesting that all can go and that we be blasé or cowboy about it at all. But I think there are cases when we do have time to get the diagnostics correct in the donor, treat the donor for a bit of time, and know what we're getting into with our recipients, that changes that calculus in terms of this being an absolute no-go to yes with caution. And just as Cynthia said in the last case, as far as which recipients should we be willing to take that risk, and thinking about the where we are on the continuum of risk aversion.
Perfect. Excellent. So I hate to cut it off because there are still a couple of questions, but we are over on time. For those remaining questions, we can send the questions to the panelists afterwards, and they can type up short answers, and we can send it out to the respective people. So now I will turn it back over to Brian, and then we'll close it out.
Thank you so much. AST would like to thank all of our expert panelists, the leaders of Transplant Farm COP and IDCOP, and all of our attendees for today's session. Please remember to complete the evaluation survey after the session closes. This recording of the session will be available on the AST YouTube channel on the COP Hubs next week. Thank you again for today's excellent session.